is Abigail. I'm going to be the technologist.
And I am Amanda, and I'm going to be the patient.
Today, we will be demonstrating the positioning and procedures of the esophagus and upper gastrointestinal tract. The demonstrations are of the overhead projections that are done once the fluoroscopy study has been completed. The first projection the technologist will do is the PA oblique projection, RAO position of the esophagus.
All right. Appreciate it. Please, ma'am.
The technologist starts the exam by getting a 14 by 17 cassette and placing it lengthwise in the table bucky. It is important to make sure to put the bucky at the head of the table so the technologist has room to work with. Place the patient in a prone position on the table with the pillow at a diagonal to the shoulder on their right side. Next, flex the patient's legs to help support the 35 to 40 degree into an RAO position. Note, if the patient is smaller, you will need to rotate them more. For a larger patient, adequate rotation is less. Then, have the patient turn their head to their left to allow ingestion of the barium while obtaining images. Once the patient is in position, the technologist will need to physically localize T5 and T6. To localize T5 and T6, first localize T7, the external landmark of the inferior angle of the scapula. Once T7 is located, center the central ray 1 to 2 inches superior to localize T5 and T6. To center left to right, first localize MSP at the spine and then 2 inches laterally towards the elevated side. The central ray will be perpendicular to the image receptor. Once the patient is centered, collimate to an 8 by 17 lengthwise field. And lastly, place the left marker directly on the cassette inside the table bucky on the lower corner of the patient's left side. The source to image distance will be 40 inches. For technical factors, the KVP will fall between 110 and 120, and the mass will vary between 7 and 8. Once everything is aligned, go through the instructions of the exam with the patient and make sure to give the patient the cup of barium with a straw to drink from. You will instruct the patient to swallow 2 mouthfuls of barium, and on the third mouthful, have the patient hold the barium in their mouth and instruct them to swallow while simultaneously taking the exposure.
Take your first sip, another one, hold the next one, now swallow, eat.
The next projection we are going to do is the PA oblique projections RAO position of the stomach. The objective of this exam is to show the C-loop of the duodenum and the pyloric canal, duodenal bulb, and the junction between the pylorus and the duodenum. Since the patient should already be in the RAO position, all the technologist needs to do is increase the patient's rotation to be between 40 and 70 degrees, depending on their body habitus. For this projection, a rule of thumb would be that the patient requires less rotation if they are smaller and more if they are bigger. The cassette used is 14 by 17 lengthwise and should be collimated to an 11 by 14 field once centering is completed. For this exam, the centering port is at the pylorus of the stomach and the central ray is perpendicular to the image receptor. To locate the pylorus, the technologist will need to find the lower margin of the patient's ribs on the left side of their body and then center 1 to 2 inches above that. From this position, to center left to right, the technologist will go halfway between the spine at MSP and the elevated lateral border of the abdomen. Place the left marker on the lower corner of the patient's left side in the collimated field. Next, make sure that the source to image distance is 40 inches. The technical factors for this exam should be 110 kVp with contrast and between 90 and 100 with air. The mass settings will fall between 10 and 12. Instruct the patient to suspend their breathing at the end of expiration.
Taking a deep breath, blow it out, and hold it out. Eat, breathe.
The next projection is a PA projection of the stomach. This projection is utilized to see the mucosal lining of the body and the pylorus of the stomach with contrast and air. The patient will lay prone on the table, shoulder abducted to 90 degrees above their head. Make sure that the pelvis and hips are in the same plane and that the patient is not rotated. The cassette is still 14 by 17 lengthwise, but the field will be collimated to 11 by 17. The central ray is perpendicular to the image receptor at the level of L1 and L2. Centering left to right is halfway between MSP and the lateral border of the abdomen on the patient's left side. The technical factors are to be set to 110 kVp with contrast or 90 to 100 kVp with air, and mass to fall between 8 and 10. Lastly, instruct the patient to suspend their breathing at the end of expiration.
Taking a deep breath, blow it out, hold it out, eat,
The
breathe,
next
and relax.
The next projection will be the right lateral projection of the stomach. The purpose of this projection is used to visualize the right retrogastric space of the stomach. Have the patient roll up onto the right side, facing the technologist. Ensure that the patient is in a true lateral position by flexing their arms at a 90-degree angle up by their head and flexing their knees. The cassette size is 14 by 17 lengthwise and will be collimated to 11 by 17 field size. The central ray is perpendicular to the image receptor and centered to the pylorus. To localize the pylorus, center 1 to 2 inches above the lower rib margin and halfway between MCP and the anterior border of the abdomen. Place the right marker on the lower corner of the light field, either tabletop or on the cassette in the bucky. Make sure that the source to image distance is set to 40 inches. The kVp used will be 110 and the mass will fall between 8 and 10. Lastly, instruct the patient to suspend their breathing at the end of expiration.
Taking a deep breath, blow it out, hold it out, eat, breathe, and relax.
The last projection is the AP projection of the stomach. The purpose of this projection is to see the fundus of the stomach filled with barium. Have the patient roll and lay in the supine position. The patient's arms and shoulders will be slightly abducted away from their side with their pelvis and hips in the same plane to ensure that the patient is not tilted or rotated. The cassette is 14 by 17 lengthwise with a fully open light field. The central ray is perpendicular to the image receptor at the level of L1 and L2. Centering left to right is halfway between MSP and the lateral border of the abdomen on the left side. Centering top to bottom is halfway between the xiphoid tip and the lower margin of the ribs. Place the marker to the patient's anatomical side, either in the collimated field or in the cassette. The source to image distance is 40 inches. Lastly, the technical factors will fall between 90 and 100 kVp with air and 110 with contrast. The mass will be between 8 and 10. Instruct the patient to suspend their breathing at the end of expiration.